Hit the subscribe button or visit us at auau.auanet.org.
Okay, well, thanks for joining us on a rainy Sunday afternoon. I'm Tom J. Ram. I'm a urologic oncologist in Nashville in a big private group, and our course here is kind of a little bit of a different type of course where we're trying to help urologists understand and kind of assimilate the checkpoint inhibitors, the understanding of how to manage side effects, but also just kind of the understanding of the drugs, the indications, into their own practice. And so I've got two excellent faculty members with me who have a lot of experience with this topic, and hopefully we'll give you guys some practical tips on kind of what we've seen managing side effects of these drugs, when to give it, when not to give it, and kind of what you need to carry this out in a structured and a skilled manner. So, like I said, I'm Tom. I'm a urologic oncologist in a big group in Nashville. I run our advanced cancer center where we give some of these advanced therapies. We have a lot of clinical trials, and we try to kind of find novel solutions for some of our patients. And I'll let our other panel members introduce themselves. We'll start with Dr. Rini.
Brian Rini. I'm also in Nashville, but I'm a medical oncologist at Vanderbilt.
Yeah, my name is Michael Johnson. I'm a urologist at Washington University in St. Louis. My background's a little bit special in that just last year I used to be in private practice. I was there for a couple of years, and so I have experience with checkpoints both in the private practice realm as well as academia.
So a couple of housekeeping things, so bear with me here. This course utilizes audience response questions. To participate, you will need to scan the QR code located on the handouts near the entrance to the meeting room or on the screen. The AUA annual meeting app is available and free to download. When you download the app, you'll be asked for a username and password, and then all the course materials are available on that app. Use your email that you use to register to log in for the app. So the AUA policy states that all authors and presenters must disclose prior to their presentation all relevant financial relationships, and you see ours on the slide up currently. These disclosures are also posted on the AUA annual meeting website for easy access. Please remember to silence your cell phone. No photos, video, or audio recordings are permitted, and courses are selected based on evaluation results. So after the course is done, if you're visiting with us live or streaming, please fill out the evaluation for the course and what you liked, what you didn't like. And then for every course evaluation that's done, your name will be entered into a complimentary registration drawing for the next year's AUA meeting in San Antonio. Okay. So with that, I'm just going to real quick go over some of the objectives and why we're here, and then we'll get to the heart of it. So really the goal, we're going to try to simplify this and make it pretty structured in that we really have three objectives. Identify common and uncommon presentations clinically of immune-related adverse events, to try and develop a pathway or an understanding of how to successfully manage adverse events from checkpoint inhibitors, and then also to develop some clinical infrastructure to prevent and prepare patients, and also providers, which is an important part of this, for immune-mediated adverse events. So with that, the outline, and each of us are going to kind of tackle a separate topic here while intermingling cases, is an introduction to IRAES and the pathophys, strategies for treatment, and then strategies for prevention. So with that, Dr. Rini will come on up, and he is going to talk the first section. There will be some audience response questions intermingled. We can try and pause and wait for the responses, and then we'll go through those questions in detail.
Thanks, Tom. I notice we're not allowing people to sit on the left side of the room, so it's good. All right. First question, which of the following is an uncommon immune-mediated adverse event, immune-related adverse event, or IRAE? Rash, transaminitis, myocarditis, or hypothyroidism? Well, the answers will pop up.
You can go to the next slide, and I think they allow them to log their responses.
Oh, I see.
The QR code is where, guys? Oh, go back one.
Oh.
Right there. I thought that was just for optics. I didn't think that was actually.
All right, has everyone got it? Anybody? Good? Okay. All right, which following is uncommon? Rash, transaminitis, myocarditis, or hypothyroidism? Yeah, correct, myocarditis. So myocarditis is extremely uncommon, but it's about 50% fatal. Rash is probably the most common. Thyroid endocrine disorder is very common, and transaminitis fairly common as well. Obviously, just broad statement across many different types of immune therapy. So I have some cases and then some didactic slides intermingled. 50-year-old man with kidney cancer has 3 doses of Ipi/Nivo. As you know, Ipi/Nivo is one of our standard frontline regimens. Calls with 10 episodes of loose, watery bowel movements. And so the question is, what is the next step? Tell the patient to take some Imodium, bring him in for some stool cultures, just tell the patient to stay hydrated, prescribe steroids with or without an emergency room visit, or prescribe antibiotics. I think if I go, yeah. So otherwise healthy, frontline metastatic patient, 3 doses of Ipi/Nivo, has sort of sudden onset of watery diarrhea. So yeah, I think that's right. I mean, I think what we would do, it sort of depends on what day is it and what time of day, right? If it's the middle of a work day, we'd have that patient come in, probably set him up for some IV fluids. This sounds like immune-mediated colitis, right? This isn't, the patient only got immune therapy, right? So any toxicity is going to be immune-mediated by definition, but this isn't sort of subtle onset of a loose stool or two. This is sort of, rapid onset and explosive, and that's sort of one of the characteristics of immune-mediated diarrhea. And again, whether if it's late in the day, they may need an ER visit. If it's during the day, I would probably just see them and deal with it in clinic. Obviously, stay hydrated is not a wrong answer, but this sort of requires probably a next level of care for this patient. Antibiotics don't have a role. I don't usually get C. diff in cultures. I don't think it's wrong. It depends on the context. Of course, if the patient was on antibiotics, it wouldn't be wrong to do, but I would say I don't do that routinely for these patients. All right, so the common theme, and the way I describe it to patients is, we're giving you drugs to rev up your immune system to cause inflammation. We want that inflammation to be against the tumor cells. The side effects come when the inflammation is against normal cells. I think this is, animated here. So on the left side of the slide is, relatively common ones, and on the right side are rare ones. But what I tell patients is any organ can become inflamed. And then I'll usually go down kind of that left side and say, but commonly it's your skin causing a rash, it's your gut causing diarrhea, and so on. But I do say any organ can become inflamed. And then you see the rare ones in the myocarditis, which is one of the answers on the question. But it's really any organ. What's the mechanism? And again, on the left side is the text of, that I just said, right? That it's really 2 sides of the same coin, right? It's inflammation, it's T cells attacking antigens. They're normal self-antigens in the case of toxicity, and they're tumor antigens in the case of anti-tumor effect, right? And that schematic just sort of takes you through in various organs sort of, what happens. But I think it's relatively straightforward in terms of what's going on. This is similar. I'll skip that. This is an old slide. You can see the JCO reference from over 10 years ago. So this is in the early days of PD-1 inhibition and CTLA-4 inhibition in melanoma. And I like it because it gives you that timing, right? It's sort of another dimension as opposed to just a list of side effects. So there is a different kinetics. There are different kinetics to each of these immune-mediated adverse events. So rash is almost always the first. You see that's the sort of light blue line. I don't know if you can see it. And usually in the, again, 6 to 8 week range. And again, remember, this is in the Ipi/Nivo, right? So this is dual immune therapy that's given for melanoma, it's given for kidney cancer and some other diseases. Then you get liver toxicity, diarrhea, and the endocrine toxicities tend to occur a little bit later. So pituitary dysfunction or hypophysitis, or I would lump in there thyroid dysfunction, adrenal dysfunction, pancreatic, right? Any of the endocrine organs that can be affected by these agents. Some of these toxicities can be fatal. If you look at, certainly at least in the advanced setting, the patients that I see, there is a small but defined number of patients who have fatal toxicities. I think the good news now is that, unlike 10 years ago, any emergency room doctor has seen patients who have this, any primary care doc. So they're aware of this class of medicines. They're aware it's not chemotherapy. They're aware that these patients need, urgent intervention and often steroids. So that sort of initial education period, I think, is done, and there's general recognition of this class of medicines, right? And it's again not the same as other classes. So then you can see just, I guess, in that sort of waterfall type swimmers plot on the right there, sort of the number of cases and then the fatality rate. And the one that sticks out is myocarditis, of course. And pneumonitis I would put up there. In our patients with kidney cancer, with one kidney, nephritis obviously can have significant implications. So if you treat enough patients, you will see this, and it's really just a matter of being aware, right, and not being aware that this can occur and having a very, very low threshold to test patients or refer them to specialists.
Brian, let me ask you a question. What do you make of kind of the statement that I've heard before that, listen, in non-metastatic disease, in urologic disease specifically, you're treating healthier patients, less disease burden, and some of the data that was initially shown on, how patients did on checkpoints from years ago in, end-stage disease and pre-treated disease may not be as relevant to this population. Does that hold any water?
I don't know that I really agree with that. I mean, most of the data, and again, I see mostly kidney cancer, most of the data we have for immune therapy is in the frontline setting, right? It's our initial therapy. So these are generally pretty healthy patients, as you know, right? I mean, not always, but pretty healthy. Now, they're probably not as healthy as the adjuvant setting. I'm not aware of any data that severity of toxicity is related to disease burden, at least in the advanced setting, right? I mean, it kind of makes sense, but I'm just thinking, I'm not sure that I've seen anything along there. And just my experience, now, as you know, in the adjuvant setting, we're just giving single agent pembrolizumab. In the advanced kidney cancer setting, we're giving multiple drugs. So it is different. But I would say my anecdotal experience, and I think the numbers would bear this out, is that I don't really see a huge difference in toxicity. Yeah.
Can I ask a practical question?
Sure.
So when you're counseling patients on IO therapy, you're covering a lot of information here. There's a lot of data. How much of this do you convey to the patient specifically? Are there things that you say, well, we're giving you this for kidney cancer, I'm really looking out for nephritis, or are you saying, well,
I talk about, I say, the line I said, we're causing inflammation, that's the mechanism. I said it can be any organ, but here are the common ones, and I give them 4 or 5 common ones. We have handouts we can give them. Mostly what I say is, listen, if you have problems, you have to let us know. Like, you're not bothering us, that's our job. Message us during the day, call us, get my fellow on call at night. I give him my email, I say, if it's nights, weekends, holidays, just email me. I say, my line is, if I'm not sleeping or on a plane, I will answer you. Right, so I think you just have to give patients that permission that, you can get really sick with these. When I'm giving single agent pembro in the adjuvant setting, I say, listen, 8 out of 10 people do just fine with this therapy, and it's going to be a relative non-event. Mm-hmm. But if you're in that 1 or 2 out of 10, it could be a significant, life-altering, even a life-threatening event. So you don't want to scare people, but you want to just give them permission that, if you can get really sick and you need to let us know, because early intervention is key, of course. But I don't go down the list, and and if a patient had a pre-existing lung problem, well, then I'm probably not treating them. If they had a reason to highlight one of the more rare ones, then they're probably in a category of patients that I wouldn't treat. All right, 50. Didn't I?
I think this one is 3.
Is this the same one?
Was it?
Oh,
it was underlined 3 episodes, so I don't know if that was.
No, I think we're supposed to ask the question before and after.
Oh. Okay.
So just vote again. Sorry, it's the same patient who had 3 doses of Ipi/Nivo.
Time's up, Brian. You lost the game there.
100% awesome. So just to continue this case, patients treated with steroids with some improvement, but then relapses upon taper, and this is not uncommon at all, right? So whether you use IV or oral steroids is one of those, art of medicine sort of things. I tend to try to get away with oral. But if a patient's sicker, then I'll bring them in, give them fluids, give them a dose of IV, and then send them out. Usually 1 milligram per kilogram is the starting dose, so somewhere in the 60 to 80 milligrams of prednisone daily. And then there's no real rules around taper, right? It's just one of those, how's the patient doing? How sick are they? What's their comorbidities? You know, you want to, I try to taper a little more quickly to get down into the 20 milligrams a day, but then from there I'll go slower. Because what I found when I was giving these drugs years ago early on is that if you go too fast, people always relapse. Always, always, always. And then you end up starting over again and the patient's bummed out because they've got steroids, you know. So I tend to try to get fairly quickly, and by that I mean call it over 2 to 3 weeks down to 20 milligrams a day, and then I'll take a good 4 to 6 weeks to try and get down to nothing potentially, but some patients can't get down to nothing. Some patients are going to be on 5 for the foreseeable future. So this question is really around what do you do if the steroids aren't working? So initially treated with steroids, some improvement, but then relapses upon taper. What's the next step? And let me just flick to the actual answer slide. So just increase the steroids, give them 100 milligrams of prednisone, add infliximab, mycophenolate, MMF, metronidazole, or get a fecal leukocytes test. So yeah, kind of a mix of answers here. I'll go through, I think the slides sort of cover this. I think the point is that steroids are our first line of defense for everything, right? Because they're sort of cheap and easy, but that there are other drugs you can give, you know, when patients become steroid refractory. I'm not sure this patient would quite qualify as steroid refractory, right? He's had sort of one attempt at steroids, so I probably would initially think about going back up on the steroids, but I have also learned over the years to have a very low threshold to introduce other agents like infliximab, which is very useful for this immune-mediated colitis.
So real quick, Brian, can
Sure.
you just, what is the, so, you know, for us urologists, there was already a lot of hesitation about steroids and steroid taper, and we've kind of, a lot of us have started to kind of get over that, but infliximab and mycophenolate are kind of a, what in the world are you asking me to do now? So can you just briefly talk about what the process is and how you follow those patients?
How do we follow patients who
So
need
what's the
another
process
layer?
for example, if you decided to give that patient infliximab, it's an injection, an infusion,
It's an infusion
every
yes,
2 weeks, right? Or
TNF alpha inhibitor. So if we're in the anything beyond steroids, then we're in this case, the patient's going to see GI, they're going to think about getting scope. You know, this isn't just us sort of doing it off the cuff in the office. Steroid, sure, we're pretty comfortable. I don't necessarily refer all my colitis patients to get a scope. That's a question that comes up. It's never wrong to scope these patients and get a biopsy to make sure you know that that's what this is, but usually the clinical scenario is so typical that I don't necessarily feel the need to do that. Again, it's one of those things where it's not wrong to do, but we don't commonly do it. But if we're getting into the steroid refractory or talking about some of these other agents, then even myself, who gives these drugs all day, every day, is pulling in other specialists. I think that's probably the best take home is that, you know, there are hopefully, you know, if you're going to start giving these drugs, you need the cell phone numbers of some specialists, a GI doc, a dermatologist, a hepatologist for liver function. You know, you need ready access and contact to some people who have that organ-specific expertise for help, right? And that's perfectly fine. That's you know, to be encouraged. This is just sort of describing immune-mediated colitis. We've talked about this a lot. IPI is, you know, PD-1 inhibitors are generally well tolerated as single agents. You put IPI in there and all bets are off, right? The combination in IPI by itself is a very toxic drug, and that you know, at least doubles the patient's chance of immune-mediated toxicity. And you've read the other bullet points there, and you could see that sort of nasty colitis. Just some other tidbits about immune-mediated colitis. Fortunately, perforation is rare. NSAIDs are a risk factor. And G2 is grade 2 or grade 3. And you see the definitions in parentheses there. And this is an area in medical oncology where we say, gee, you know, I had a patient on ipi-nivo and they got 3 doses and they had grade 3 colitis. Do I give them that 4th dose or not? And I think, again, this is where my thinking has evolved. At first, I was trying to push everybody to get 4 doses, and now I don't do that at all. If somebody has grade 3 of a serious toxicity, you know, a serious organ toxicity, not like thyroid or something, then I'm probably done. That patient's probably done with IPI. And there's absolutely nothing magical about 4 doses of IPI. That's how it was given in melanoma, and that's how we do it for everybody, of course. That's not going to be appropriate for everybody. I mentioned about endoscopy, you know, and then some salvage agents. And we have Doug Johnson, and actually I should have given Doug credit because all these slides I borrowed from him. Doug is a melanoma doc and has given a ton of these agents, very involved. And we're also starting to do trials of novel drugs to treat immune-mediated toxicity. So there are a number of compounds out there in the development phase to treat this. All right, let's go on to the second case. So resected bladder cancer on adjuvant nivolumab, and has sort of a faint itchy rash on arms after 5 doses. Nivolumab's given every 4 weeks, so we're a few months into this. And let me just switch to where you can vote. So faint itchy rash in the arms, given milligram per kilogram of prednisone, itraconazole, antifungal, just warm compresses, hydrocortisone 1% cream, or do a skin biopsy. It's a pretty good question. I like this one. So half and half. For high-dose prednisone and hydrocortisone. I would almost always start with hydrocortisone cream, in patients. I mean, a milligram per kilogram of prednisone is no fun. Who's been on prednisone in the audience? I had poison oak once, and I was on like 40 milligrams. It was awful. Like, I'm never doing that again. It was awful. Now we're talking about 60 or 80. So I probably wouldn't for just this, not that much surface area. It's faint. Sometimes the patients don't even mention it, You almost have to pull it out of them because they're sitting there in your office doing this. So I think I would usually start with just hydrocortisone cream. And again, skin biopsy, same really as with colitis. I don't think it's mandatory. I think it's not wrong to do, but I don't know, in your centers, getting somebody into dermatology in Vanderbilt, I'll be retired by the time they get that skin biopsy, so.
So you mentioned something interesting, and I think it's something we talk about in our urology meetings on this, is you almost had to pull it out of them. It kind of, to me, it makes me think, the thing I worry about is sleeping on a mild or a minor side effect, right, and letting it progress. Do you have a formal intake form? Do you have an MA, or do you have someone say, hey, you're on IO therapy, fill this out before the doctor sees you so he can look at it? Do you have any sort of process in place? Because again, the case you just presented, I worry about, the patient doesn't say anything, and then God forbid Stevens-Johnson shows up, and then something weird like that happens.
We don't have an IO-specific intake. We obviously have intake forms like everybody does, and they go online and you see the list. I think that's probably less useful, those intake forms, to be honest. So, but we don't have one specifically. But because we give so much of this therapy, every single person that touches the patient, so to speak, is going to be aware of it. Mm-hmm. And very often I'll get the rooming nurse MA will come and say, will tell me about stuff that they sort of gathered over their interaction with the patient. Okay. And I guess the other thing I would say that's maybe somewhat related is, I'll have my clinical nurse call that patient in a week or something. I'll very commonly say, hey, why don't you call Mr. So-and-so in a week and just check in and stuff. So it's kind of puts the burden on us and not just the patient. As you know, some are very readily, they'll message us in our system and it's easy and it's great. And other people, again, they just don't want to bother us, and so they don't message until it's too late. So depending on what side effect and the severity, we sort of have this sort of follow-up built in. So let's take this case a little further. So let's say the rash worsens, patient comes back in, call it in 2 weeks, 2 to 4 weeks. And so now it's, more of a diffuse rash, and it's really bothering the patient and keeping them up at night. Just go to the voting slide. So now would you give systemic steroids or the other things? Skin biopsy. If you could find a dermatologist friend, you're going to be.
Complete rash excision.
So yeah, I think I would probably give prednisone. Sometimes, when you're making these questions, you can't put every single thing you might do. I might not give a milligram per kilogram. I think it kind of, again, that's a lot. So sometimes I'll try to, and I've been burned by this, so maybe I'm not advocating for it. I'll be like, let's just give you 20 milligrams of prednisone. Let's give you 20 for 5 days and see what happens, and try to get away with less than the full guns. Not for colitis, not for the serious stuff. But for rash, where you can see it, and if it worsens, the patient's going to know. I don't generally view that as life-threatening. So I'll try a middle, call it half of a milligram per kilogram. Sometimes it works great, and then at other times it doesn't work, and my APPs yell at me like, "Why did you give that patient low-dose steroids?" So I don't know. I don't know that there's any studies on that. But again, it's one of those sort of art of medicine things where you're trying to treat it, but you're not trying to over-treat it, of course.
So after
Sure.
5 days of 20 milligrams, do you taper?
I probably wouldn't. I probably would just, if it's just 5 days, I'd probably just stop and see. Again, that's where my nurse would call, hey, how you doing? And if they're fine, just stop and see what happens. If they're on anything longer than a week, then I would taper. I might go down to 10 a day for a while and 5 a day or something like that. Again, just kind of make up the taper.
And Brian, is your decision to put them on steroids based on the severity of their symptoms or the total surface area? That's
both.
Yeah, both.
Yeah, I think probably more so the severity than the surface area, because I'm not calculating the surface area, right? I'm just kind of eyeballing it. So, but those tend to go together.
Yeah.
They tend to go together. But if I had to answer one, I'd say severity. Okay, sorry. All right, so this is Tom's nightmare. This now becomes blistering, or they have mucosal ulcers, etc. So now what would you do as the next step? Yeah.
I think I see where this is going.
And again, I think probably these answers, I could have fleshed them out a little more now that I'm standing here. So you're certainly going to give this patient steroids, potentially IV steroids. This is where you're absolutely getting dermatology involved and no, this patient can't have an appointment in 4 months. That's not going to work, right? This is where you're getting on the phone with your colleague and saying, I need you to see this patient. Definitely you would do a biopsy. The dermatologist would do a biopsy, and then think about management strategies from there, which would be a re-increase of prednisone or maybe some of those other agents, that we talked about, infliximab. I'm not sure that I've experienced this. I don't give a ton of Ipi/Nivo. I tend to give IO, TKI in kidney cancer, but I don't have a ton of personal experience with the rash becoming this bad. Rash, absolutely, many, many patients, but this severity of rash is much less common. All right, just a couple, again, it is most common, it appears early, it's sort of this, lacy reticular rash, usually generally responsive to topical steroids, and I didn't mention symptomatic other, medications, just Benadryl and just Atarax and things like that, and then systemic steroids if it becomes more severe. All right, next case, I don't remember how many I have, but
I think this is the last.
This last one, okay. So 58-year-old man with BCG refractory non-muscle invasive bladder cancer who get 2 doses of Pembro, comes to clinic for dose 3 and now has transaminitis with ALT, AST in the 500s. They were, of course, normal at baseline. So what is the most appropriate treatment? Steroids and monitor, liver ultrasound, hepatitis, check a Tylenol level, plasmapheresis, or mycophenolate. All over the map on these answers. So patients clinically well, they're not sick, but they're, obviously you get labs before you would administer the Pembro in this case, and they come back in the 500s. Bilirubin's normal. Probably should have said that. Yeah, I think that's right. I think I would just give steroids. I would definitely hold their dose, maybe to state the obvious, and monitor closely. And we've given a fair amount of Pembro in this setting when it was approved. Our urologist sent us a lot of these patients, and if there's not a trial, we're giving a fair amount of this. And I will say I've seen more transaminitis in this setting than I've seen in other settings. And that's, again, just my collection of anecdotes, so I'm not sure that it's unique to this setting. I know it's not unique to this setting, but I've seen a higher incidence.
NMIBC?
Yeah.
In this setting, okay.
Yeah, I've had a few patients who were on steroids for months. It took us months to get them off steroids. Yeah. Again, it's just anecdotes, so take it for what it's worth. Again, with a normal bilirubin in this clinical setting, I don't think you have to necessarily send this patient to hepatology and sort of go down that route. Again, never wrong to do, but you're not going to be able to do that on the spot anyway. C and D, no, and then MMF, you certainly can use mycophenolate for steroid refractory transaminitis. It's quite effective, and I've learned to use it much earlier. But again, at that point, you're getting hepatology and other specialists involved for sure.
In your experience with transaminitis, it's a rapid onset?
It's probably, the median's probably in the 6, 8, 10 weeks, yeah. I think. So if that's rapid, it's, within the first few doses.
Yeah, and is it one dose it's normal, the next dose it's 500, or do you ever see it where it goes normal and then slightly elevated, and then it's, keeps going up and you...
Both. And what the really hard decision is when it's 5 points above normal, right? One's normal and the AST is, and you're like, well, and the patient's like, well, I had a cocktail party last week, you know what I mean? And exactly. You're like, I don't know, So this is easier decision making, right? Yeah. Clearly abnormal. You're going to hold drug, you're going to give steroids. You will sometimes get those. Or somebody who has, Gilbert's disease and has a high baseline bilirubin, or has some, NASH and has some mild transaminitis, those real world cases, and that makes it much more tricky for decision making.
Your patients are a lot more fun than my patients.
What's that?
Sounds like your patients are a lot more fun than my patients.
Exactly. So, all right, same patient. You give this patient steroids, there's improvement. You're trying to taper it again, as we talked about before. And then as you get down, let's say to 20 milligrams a day just to make up a dose, now the transaminases go back up. You've been holding pembrolizumab the whole time. All right, so next step, same answers, I think, but. And all of these, again, I don't think there's one right answer, because as you see, a lot of these are, do I just go back up on steroids and try it again and go slowly? Do I bring in another agent and, pull the switch to get hepatology in this case involved? And even doing this a lot, I can see where, it kind of just depends, right? How sick is the patient? We all have that sense sitting in front of patients. Like, when fellows come back and present to me, one of the first questions in a case like this, I'm like, are they sick? Do they look sick? Like, are you worried about them? Like, or, oh, no, they look fine. And, those are different types of patients. So, and I think this is what we would do. We would go back up on the steroids and then just start a super slow taper. And again, I've had this exact scenario in this setting. Not wrong to get hepatology involved. As I mentioned, I've learned to use MMF a lot earlier. I never had any experience with the medicine. It's particularly effective for transaminitis.
You said PO versus IV steroids is kind of dealer's choice. What does that look like, in the real world? I mean, are you saying, okay, well, we've done PO for a while, maybe we should give it a trial of IV before we go to these other agents? Yeah. Is there a benefit of IV steroids, higher dose, if you're already doing 1 or 1.5 mg per kg? I
mean, you can get higher doses, and if there's any concern about absorption, like in the case of colitis. They might not be absorbing. So, and again, it's kind of just depends on, and sometimes you want to make sure the patient gets the steroid in. Maybe they're a little less reliable. So like, we're going to have you come back 3 days in a row to clinic. We're going to give you fluids. We're going to give you IV steroids. We've done that a little bit too. Not sick enough to be admitted. You're not quite there, but I'm a little nervous for outpatient management. And that's kind of where we've used it.
So what dose can you give in that scenario?
Like a gram of Solumedrol. Yeah. So we'll give so you give in higher doses, right? So that's sort of another escalation of steroid intensity, so to speak. Yeah.
At your institution, when you do get hepatology involved, do they ever end up doing anything?
Wait,
right upper quadrant.
Any of them in the room?
Yeah.
That's a loaded
Do they get
question.
a liver ultrasound? And
yeah, they'll usually, do the
biopsy.
laundry list of, ceruloplasmin level and all that stuff that I've long since forgotten about. Generally, and I'm never, it's never wrong. Do we find anything?
Exactly, yeah.
Almost never.
Yeah.
Almost never.
It's more just to get them on board in case something goes.
But it's let's
the
make
rails.
sure this patient didn't have hepatitis that was reactivated. Let's make sure those rare but things that certainly happen. And again, then they're on board, right? Then they're engaged, and their nurses are engaged. You know what I mean? That team is engaged in case this person does get much sicker.
I've just never seen the hepatology service actually do anything to involve it, and so I don't know if institutionally you're buried.
And it's also, what's really helpful is if you have not just a group of people who you might refer to, but there's one person who has an interest, right? An academic interest in immune-mediated hepatitis. That's great.
I agree.
Because then they're like, here's my cell phone. I'll see any patient anytime, right? That's gold. And we don't, even at our center, I don't have that for
Do you have that cell phone
organ.
number available? Yeah, that'd be great.
I'm not giving it to you, Tom, for sure. Yeah. I mean, in all our systems, we have different barriers, right? I mean, so that is it's not even implied, it's stated, that's the challenge. Yeah, and that's when I'm not just like putting in a referral and letting it go into the ether and hoping that it happens. Yeah, I'm getting somebody on the phone, whoever I can find, or the fellow on call, you know what I mean? And really sort of chasing them down. So that's just knowing your system, and maybe just putting in the referral works. I don't know. Sometimes it does, and if it's non-urgent, great, then I'm not worried about it.
I think Mike will talk a little bit about this, but the multi-do component that Brian alluded to, for medical oncologists, it's important. For urologists, it's critical if you're going to do this. And especially in the community, like you said, I've got 3 people on speed dial, endocrinologists, GIs, and it's hey, I need you to see this person tomorrow kind of thing. here's a number, can you call the patient tonight? But especially if you're kind of in community practice, we've talked about this, what multi-D looks like is different in different institutions, but for me, multi-D is having those 3 people on my starred list on my phone that I communicate with very frequently.
Yeah, I agree. So just some bullet points about this. Obviously, it's lab-based. Consider other causes like we talked about. Grade 2, grade 3, you see the definitions, which are, somewhat arbitrary, right? It's 3 times, 10 times, in terms of the grading. And then again, whether to hold therapy and then resume versus give more therapy, it depends on the clinical setting, right? I mean, we were talking before, I have a much lower threshold to stop therapy in an adjuvant renal setting, right? Where the benefit risk is very different than in an advanced setting when a patient, needs therapy. In this setting, in the non-muscle invasive setting, it's kind of in between. And how many doses did they get? And maybe we should just do the cysto early and see if they've responded. The decision to resume therapy is a very personalized one. Not only your experience, but what's going on with the patient, what's the disease, what's the benefit risk of this immune therapy in this setting, et cetera. I think I have a couple.
This is your last.
Is this my last slide? Okay. So a lot of times patients say, hey, doc, I don't want to go on steroids because that'll make the immune therapy work less well. And this is just one of many data sets. This is from Memorial, I think. Yeah, Memorial. And much of this data is in the melanoma world, as you can imagine. And if you just look at that bottom bullet in the box on the left, how there's really no difference in time to treatment failure or survival. So you don't want patients on high doses of steroids before you start treatment. There are some data that it could reduce the efficacy, but once they're on treatment, they need steroids, they need steroids. But I will occasionally get a patient, a little more sophisticated patient usually, and they've been on the internet somewhere and said, well, steroids make immune therapy work less well, but I think you can reassure them that that's not the case.
Any thoughts? There's similar data on antibiotics during checkpoint inhibitors. In our population, obviously, we have a lot of patients with urinary tract infections, BCG-related infections, dirty urines. And there's some data that, there's some microbiome kind of alterations that may change the efficacy. Any comments to the urologic kind of provider on try to minimize antibiotics? Does it matter?
Yeah, I think it might matter. I don't have a slide on those data, but I think there's been studies of antibiotics. I think it's either within 14 or 30 days of the start of immune therapy, much like the steroid studies. And as Tom alluded to, the microbiome, which is a whole fascinating topic in and of itself, is clearly influences response to immune therapy, and antibiotics can change that environment. That's the mechanism of how they might be adverse in this circumstance. So I think it's sort of try to avoid if at all possible, or maybe try to delay the immune therapy depending on the clinical scenario, but it's sometimes you don't have a choice, right? Obviously you want to treat infection as appropriate. In an adjuvant setting, they can often wait a little bit to start, right? I mean, they can wait, depending on the timing. So I think that understanding of that, of the microbiome and what to do in that circumstance is still developing.
Great.
All right, thank you.
Okay, so that was great, and that was, I think, a really good kind of scaffold for a lot of this. And I think one thing I kind of got out of that is that there is, as many times as we want to put things into structure and boxes and, hey, give me a guideline, there's an art of medicine thing to a lot of this. But certainly, we all have to know the toolbox and what's available. So I think we'll talk a little bit about strategies for treating IRAEs and kind of through a urologic lens, as someone who obviously is somewhat new to this, but in our practice, we've been giving this for several years. We had a lot of protocol-based trials with this that we started 5-6 years ago, and I think we've learned a lot as a urological community. So my AR question is 67-year-old female on adjuvant pembro after a nephrectomy presents for initiation of their second therapy, mild skin reaction, likely due to immunotherapy. So, pardon the overlap a little bit, but I think now you guys should be pros. So, what's the appropriate management? Discontinue pembro and start steroids, continue pembro and topical cream, continue pembro and infliximab, or switch from pembro to erdafitinib, which really makes no sense with renal cell carcinomas. So I think we kind of hinted on this. It appears to be a mild skin reaction. But it was interesting, I think, what Dr. Rini said about you just kind of have a different perception of
adverse events in the adjuvant setting, meaning that they're theoretically NED, they don't have active disease, you're giving them therapy to try and prevent recurrence as opposed to try to treat active disease. I think that's an important concept. So this is kind of my my slide about adverse events for two urologists. We've done in kind of large group meetings and settings, we've done surveys on what would prevent you, or what is the thing that's preventing you from considering giving this. And by far, every single meeting, it's concern about the adverse events. And I think it's very reasonable, all things considered. Just to kind of put it in perspective, for high-grade adverse events, and there's not a source or a citation on this, so I apologize, but this is kind of amalgamated data across a lot of different sources. For high-grade effects, a lot of us are familiar with oral oncolytics for prostate cancer. A lot of our centers are giving these drugs. You're looking at about a 5% rate of clavien 3 or higher adverse events. And I think for most of us, that's a comfort zone. We're familiar with these drugs. We give these very frequently, and we feel pretty good that we can manage these side effects because, frankly, patients do really well on them, right? Sometimes you can dose reduce, sometimes you can hold them. But it is quite rare as an advanced prostate cancer provider to have to switch gears, discontinue, or God forbid, admit someone to the hospital. So with that, kind of in hindsight, IO is about a 20%, kind of all comers, clavien 3 or higher in the kind of in the urologic literature. And then chemotherapy is about 40%. So we kind of look at the chemo as being an extreme, and kind of if you look at oral oncolytics as being, what we're familiar with, then you can put IO somewhere in the middle. What's tricky is it's a challenging adverse event profile that has somewhat unpredictable onset, duration, and inciting factors. You can have a perfectly healthy person that really has no toxicity that develops something significant, and you can have someone, I have some patients in their 80s who I was somewhat reluctant to put on checkpoints for localized disease or maybe on a protocol, and they've done really well. But I think, and Dr. Johnson will talk about this, is the champion physician and the team really needs to become fluent in this language, if you will, of how to identify side effects and how to triage them effectively, and trying to get patients early treatment and prevention, I think goes a long way. So big picture, the way I look at it, mild toxicity, we've kind of discussed this, but kind of this question of, is this affecting your daily life? So someone comes in with a really dry cough that's just kind of nagging a little bit here and there. It's kind of grade 1 by definition, not really affecting activity, their daily activities. But if someone says, "Well, gosh, I'm coughing, in huge spurts, and this is really bothering me," you can hear him coughing on the phone. That's kind of a different situation. But really, most of the side effects, and it's not 90%, but it's probably 50 to 60% are going to be low grade. And symptomatic treatment, either hydrocortisone or supportive treatment, with potentially skipping a dose or two, tends to be the right answer. And then, as we talked about, you get into your moderate tox and your severe tox, and I think that's where we have to kind of understand, and we have to kind of prepare ourselves that these can happen. You will have to give steroids if you administer this yourself. Absolutely, you will have to do that. And if that's something that you don't feel comfortable doing or you don't want to do, then you shouldn't be giving these treatments, period. And then severe toxicity, it should be discussed with the patient that it's rare, but it's possible. It's very important that you call us if something severe is going on. And it's very important you tell your healthcare provider, whoever sees you, that you're on these treatments, because obviously you're going to manage that a little bit different. So kind of illustrated in a case, 66-year-old female on a clinical trial for muscle-invasive bladder cancer who was cisplatin ineligible. She received Pembro alone prior to her cystectomy. So her starting creatinine is 1.67, hence the cisplatin ineligible. There was mild hydronephrosis on the left side. We see this obviously quite a bit in our muscle invasive population, patients who are probably pathologic stage 3 with hydronephrosis. After her second infusion, she began to have lower extremity edema and excess fatigue. Her creatinine was up to 2.4. She was instructed to hydrate. Infusions were held. A repeat check 1 week later, her creatinine was 3.24, and she really hadn't improved. So as a urologist, we have a limited kind of toolbox of, oh gosh, this must be surgical. So we performed a retrograde pyelogram, and there was some left hydronephrosis. and a stent was placed. And so the thought is as well, if we can decompress the kidney, hopefully that'll bring her creatinine down. Kind of at the same time that all this was going on, I was like, well, this shouldn't be happening. Her creatinine shouldn't be rising with this mild degree of hydronephrosis. So I started prednisone, and a nephrology referral was made. After 1 week, her repeat creatinine was 2.6. And kind of in hindsight, I was like, well, now I don't know if it's the stent or the steroids that are making this difference, but I'm pretty sure it's the steroids. We held the infusion. Her steroids were continued, and her creatinine normalized after 6 weeks of steroids and the taper. And I think this was certainly immune-mediated because, again, she didn't have this degree of creatinine elevation with, kind of chronic hydronephrosis. So she was removed from the trial and underwent a cystectomy. And so I think nephritis is an important one for us because there's a lot of confounders as urologists. You're dealing with patients that may have hydronephrosis, potentially bad renal units. They have a lot, nephrotoxins that could play a role. It's somewhat rare, but I think we'll see it more in our population. If you do a biopsy, you'll see an acute interstitial nephritis. Most of the time, biopsy is not needed, and I think it's probably pretty rare to have to do this. Majority of patients, you're going to start seeing this somewhat substantial rise in the creatinine. It tends to move up fairly quickly, and so I don't know that he's saying, okay, we'll hydrate, we'll see in 6 weeks is the right answer. I think you want to keep a close eye on this. And then again, as urologists, I think common things are common when it comes to elevated creatinine, so you have to image the upper tracts, you have to make sure that they're not dilated, you have to try and stent them or divert them if they are to see if that will help. Sterile pyuria is something you can see. 2 mg per kg is advised with a longer taper, and kind of there's this notion of rebound kidney injury. I guess any questions, any comments from the panel on 2 mg per kg? That seems like a high dose.
Yeah. I haven't done that high for nephritis, and I'm not aware that it's different than the other one. So I generally, start with around 1 milligram per kilogram. This is one that scares me.
Yeah.
Right? Because again, in the adjuvant setting, renal, you obviously have one kidney. In other settings, I don't know. As I mentioned from up there, I have a very low threshold. Any sort of creatinine bump, unless there's another cause that's easily fixed, is usually the end.
Yeah.
The end of the immune therapy.
Yeah, I agree. 1 milligram per kilogram sounds reasonable to me. And now that you tell me more about, this, your hesitations, I might have a lower threshold to stop it in the adjuvant setting as well.
It's an interesting space. I mean, if this becomes approved in the neoadjuvant space for bladder, I mean, would that change the way you approach, that clinical question is, okay, well, you're trying to get them through 3 or 4 cycles of, they're cis-ineligible. Or would you kind of say, well, let's just forget this, get a cystectomy, and then we'll deal with it on the back end?
I probably would like the latter, just sitting here. I think it depends how those, obviously we don't know how those data sets are going to turn out and what standard and all that, but I think it's going to evolve a lot. And again, the clinical setting and what you're trying to achieve and the benefit risk is everything.
So general toxicity management, I have a couple of kind of protocol slides basically from ASCO and some of the governing bodies that have put out some literature on this. And I think this is, again, good for kind of a foundation. But I think as we talked about, not all hard and fast, but steroids are the cornerstone for these adverse events. Mild reactions can be treated with symptomatic supportive things like topical steroids. And then, like Dr. Rini mentioned, oral is preferred. IV may be used when absorption is compromised. And then in moderate cases, grade 2, you've got to think about kind of holding the drug and then adding steroids. And then severe cases, tend to be steroids, and then there's, these other options, mycophenolate and infliximab, tend to start with steroids first and then maybe progress to these.
Could I just make a quick comment, Tom? As mentioned, there are a number of societies that have these guidelines. ESMO, ASCO, SITC, probably other ones I'm forgetting. I would get a copy, print it out, put it in your clinic. I have an electronic copy on my computer, laptop. It's just a nice guide, and they're only guidelines, right? So one grade 3, you might treat like a grade 2 or vice versa, but at least put you in the ballpark if you're not as familiar, and I still use it, so.
I like the ASCO guidelines. Do you have a preferred one that you?
I don't No, I don't have a preferred
There's an
one.
app, isn't there? Isn't there an ASCO app that has it on your phone?
I don't know. I have a
I'm
copy
sure.
of the PDF like readily available to me. At
I
all
have
times.
one that you can, and I'll find it in a second, but you can search diarrhea and it just gives you the, algorithm. So kind of leading into ASCO guideline statements, I kind of pulled out a couple that I think are important just for a broad understanding of this. High level of suspicion that new symptoms are treatment related. So what I would say is, I tell patients anything new that pops up. So forget I have had an old cough for 3 years and then we started this and now, that's there. Anything new that starts with treatment, to me, is treatment related, and we'll figure it out, right? So call me and tell me. You don't need to discontinue for small, grade 1 toxicities. And I think, again, a lot of urologists, and my discussions with them is well, they get really, really nervous about some of these early toxicities, and then they hold patients off for a long time. And obviously it's good to be cautious, but for some of these minor toxicities, you can certainly continue treatment while monitoring these. But then, when they get up to grade 2 and grade 3, obviously that's when you need to be prompt in acting and your surveillance. And like has already been said, it's important to have a team-based approach. We have a mid-level and a nurse practitioner, our infusion nurse and a nurse practitioner who are communicating with the patient. We do virtual visits in between infusions to go through the list of questions, anything new going on. And then that's also an opportunity for us to kind of say, okay, well, your scan is going to be on this date, your cysto is going to be on this date. So it's kind of good to be organized in this whole process. And you'll pick up some small things that will require further attention. And then this concept of re-challenging, I'm curious to get, Dr. Rini, your opinion on re-challenging. What is your absolute no, I will not re-challenge? Or is it kind of one of those risk-benefit, you've got active disease, I'm going to try and push forward?
It's clinical scenario and risk-benefit. Again, in the advanced kidney cancer setting, we're re-challenging all the time.
Yeah.
So they have bad disease. In the adjuvant setting, where you're by definition treating some patients who don't have cancer, I think it's very different. So I think in grade 1 or 2, I'm comfortable. As you get to grade 3, almost anything except for maybe like thyroid disorder or something, then I'm very hesitant.
Okay, so it's interesting because you brought up your case. This is a similar case, although it's kind of not in question format. It's kind of a what in the world was Dr. J-Ram thinking kind of format. But 79-year-old male with BCG unresponsive CIS, and I have, this is kind of a different discussion, but I don't really love pembrolizumab for this indication. I think with gemcitabine docetaxel and some of the new intravesical agents, and we have a bucket load of clinical trials in this space, I try to steer patients away from pembrolizumab. I think there is a small benefit, but I think that's modest. That's just my personal opinion. But so severe bladder symptoms and intolerance toward further intravesical therapies was kind of the thing that pushed me towards giving IO in this situation. And I think Dr. Johnson would agree. There's definitely that group of patients with this disease that says, gosh, I'm so tired of catheters, and I'm so 100%. Tired of BCG. And I think that's where this makes a little bit more sense. But anyhow, this group of patients, or we started pembrolizumab, did fine, and then abdominal pain and AST, ALT elevation. The T-bili was actually elevated as well. So we began prednisone, and we saw him back. ALT and AST were now rising. T-bili is higher, and honestly, I remember seeing this patient. He was weak and he was jaundiced. So I guess the question becomes, so we did the GI consult and saw them. Is this an inpatient situation or is this an outpatient situation? Do you guys have any thoughts?
I mean, I think if you go to that fourth bullet point, if we're at that point, T-bili elevation is the real deal, right? Yeah. That, to me, that's a differentiator where I would think hard about admitting this patient. Just expedite workup, right? Then you can get a hepatology consult in a day, and you can get a liver biopsy, right? And you can give IV and steroids, et cetera. So again, not being there, it's hard to say, but there would be some triggers there that might make me think hard about it. And what's the patient's social situation? Do they live 10 minutes away or 2 hours away? Things like that.
Yeah, I'd agree. That's probably the patient that I would actually strongly consider bringing in, mainly because when I started out the IO program, I didn't have any experts guiding me who were in the area, and I said, well, this I want this to go smoothly. I know that there are other people in the hospital who are used to dealing with this. Let's just bring them in. Patients appreciate it, and you can sleep at night.
Yeah, and I think this one was a social situation kind of thing. I think we talked about bringing this patient in the hospital, and he said, well, I don't feel like I need to go to the hospital. And in the community, we get that a lot, right? I'm not going to do what you say. I'm going to do kind of what I think is right. So we try to manage this as an outpatient. Didn't necessarily work that great. But Dr. Rini's case was interesting because this was similar, just a long time of steroids. And then I think the message to kind of the group is, there is a toll that chronic long-term steroids take. In urologists, we don't really understand that. We don't see that. I mean, we give, low-dose prednisone with abiraterone, for example, but, obviously it's not the same. So you got to start thinking about those other things: ulcer prophylaxis from steroids, pneumonia prophylaxis, and these are things that your multidisciplinary specialist will know that you don't know. So if you kind of go on this road of long-term steroids, and feel free to chime in, anyone else who's been in this situation, there tends to be other things involved besides just the steroids.
Yeah, I think the PCP prophylaxis is important. If I have somebody on, it's going to be less than a month. I generally don't worry about it. But as you get into these, 4, 6, 8+ weeks, then we'll generally do it usually just with Bactrim.
Agreed.
And so then we permanently discontinue, because in theory this is a grade 4 transaminitis with really high LFT elevation, and so we discontinued permanently, and alternate options were continued. So, this is interesting because, again, monotherapy is somewhat rare. Obviously, Dr. Rini can attest that there are certainly some situations where they're using monotherapy in some metastatic patients, but just putting patients on single agent monotherapy is a little bit of a different risk profile than combination agents. So what you're seeing here is that the incidence can vary, and it can vary actually amongst certain types of cancers. And we've heard that maybe NMIBC has a little bit of a different treatment for those patients, may have a specific side effect profile. We're seeing that also in things like melanoma, non-small cell lung cancer. You're seeing certain toxicities emerge. PD-1, PD-L1, those are the ones that we're mostly dealing with here in the orange and in the green. You can see kind of the distribution of the adverse events, with most people getting skin, GI, and we'll look at some of the timings too. But common things, we like to say common things are common, and so rash, colitis, those are the ones that we're seeing more often. But it's important to understand that some of these other ones can manifest themselves. Onset of IRAES, we saw a slide very similar to this. Rash usually comes first, then comes colitis, and then the endocrine abnormalities can come kind of down the road along with the laboratory abnormalities. So there is kind of a poor man's predictor of, okay, well, if something goes wrong within the first few weeks, maybe it's more likely to be rash. But again, you don't want to kind of completely ignore some of the other things, because you can see that. But there is some kind of good foundational data here that can help you understand if they come back with a problem, what's most likely, and that can translate into counseling, right? To say, well, okay, the first couple weeks you may notice a rash, but you probably won't notice pneumonitis after the first infusion. And then I think this is important, and doing a lot of clinical trials, I think we're kind of used to this, and we have to kind of extrapolate this to patients. But a lot of these patients have a fairly strict exclusion criteria for clinical trials, and the hallmark of it tends to be autoimmune diseases and current steroids or autoimmune treatments, and that's expected based on the mechanism of action. So this is a special population. This is a high-risk group. I would strongly advise anyone treating these patients to get in a multidisciplinary forum and potentially even just refer over to medical oncology. They have significantly more expertise with these groups of patients. And then this also helps you align your consultants, right? That was already said, but I check a TSH and a cortisol on a lot of patients prior to starting. just because, sometimes patients don't know, if they have thyroid issues, if they've had a history of thyroid. So it just makes me feel better that we're not dealing with something that's brand new or is not established. And if their TSH is abnormal, I'll loop in an endocrinologist to kind of concurrently help me with the patient, and similar with some of these other things. Curious, what do people think about kind of now patients who have autoimmune disease, some of these kind of special populations? Are there groups of patients that you're saying, no, absolutely not, you're not an immunotherapy candidate?
I mean, solid organ transplant, I wouldn't, I think to me that's an absolute contraindication. The history of autoimmune disease, and there's a emerging literature, the case series and this and that you can do that depending on severity, but I think for this purpose, I think if you're thinking about doing that, you need to involve a lot of relevant people. I wouldn't do that on an island. I wouldn't do that, so certainly, for folks here. And then I don't think I have a patient with HIV on, but I don't think there's an issue. I think I might have one. I don't think there's an issue with the medications or anything, and the other things are sort of just comorbidities that we deal with, in practice.
Yeah.
Yeah, I would agree. I think the history of autoimmune disease makes me a little bit nervous, and I think I monitor a little bit more carefully. A case that comes to mind is a patient who is who's getting IO therapy, history of vasculitis and cardiac problems, and I was a little bit nervous that his vasculitis would flare up again. So we got medical oncology involved. We had a multidisciplinary meeting. We decided to check CRP, ESR a little bit more closely and keep a close eye on him. Transplant, definitely not. I don't think I've had an HIV patient either.
Okay, good. So the last part of this, I think, is Dr. Johnson's just going to talk a little bit about the multi-D aspect.
Great, thanks. So Brian and Tom have done a great job of telling us, how do I manage these? How do we identify it? And I think I have what amounts to the easy job of how do we operationalize this? And I think this is really an important part. When I started our IO program in private practice, I was the only guy who was interested in it. My partner said, you can do it, but we don't want to be a part of it. We're not getting any phone calls. You're taking handling all the problems. And so I was really had this challenge. Well, how am I going to do this? And I don't know the best analogy, but when I was originally thinking of it, I kind of thought of remember Voltron, the characters there, these superhero guys, and separately these heroes are, these guys are strong, but when they all combine, they're like a super team here, and I guess Marvel characters are probably a good example as well. But I kind of said I need to assemble my team, right? I can do things. I have certain abilities. I know I have an area of expertise, but I make no claims that I'm the expert in liver function or kidney function for that matter. And so when I think about how does someone manage these, they really have to surround themselves with their own hand-selected team of champions. For me in private practice, as Dr. Jairam had alluded to earlier, I had a bunch of people on speed dial. And so I set up a transfer agreement with my local hospital to say, well, if anyone had a problem, could I just directly admit them and have a hospitalist see them? I identified the hospitalist. I said, I might be sending patients your way who've had immunotherapy. Do you feel comfortable managing this? I got my endocrine, my GI. And so I had that. And once you had that safety net, your team supporting you, I felt much more comfortable that I could implement these therapies, identify the adverse reactions, and manage them appropriately. To that end, here's the first question. I tried to keep it pretty straightforward so that we're not rehashing things, but here, which of the following is not a typical member of a multidisciplinary immunotherapy team? If anyone says urologist, then
urologist.
You get kicked out of the room.
We walked right into that one.
Yeah, that's right. All right, and so, obviously the urologist, if we implement this, is part of the team. The nurse navigator, I think, plays a great role, and I'll mention sort of the roles that I envision people playing in various multi-D teams. Medical oncology, obviously, we work very closely with. Infusion nurses, I think, are actually extremely important because a lot of these, or I shouldn't say a lot of them, you can get infusion-related reactions, and they're also very close to the patient. And so a lot of this is how many touch points do you have with the patient? What level of comfort does the patient have conveying information on about what's going on? And in private practice, our infusion nurse would uncover things that even to the best of my abilities, I couldn't uncover. You know, I remember a situation where I went to see a patient, got them all set for their IO therapy. The infusion nurse, came back to me 5 minutes later when I was, writing a note, and like, did they tell you about their bleeding toenails? And I'm like, what do you mean? They didn't say anything. And sure enough, I went back and they had some dermatologic problem. And if it wasn't for the infusion nurse, we would have never monitored that. That person did okay, but they have a special connection. Pharmacy benefits manager, there's a lot of work with pharmacy, but a lot of the multidisciplinary team is focused around patient care. So I'd say the pharmacy benefits manager is typically not the member.
However, in private practice, the benefits manager tends to be the gatekeeper to
That's
a lot
right.
of this stuff. So
That's right.
it is an important part, and these are high cost drugs. And for those of us in independent group practice, these are buy and bill drugs. So that's kind of a different topic, but it is something to think about. You need a structure in place for that part too.
Of course. And so here's just some highlights on the workflow. How does one go about actually building this program? And so before patients get any immunotherapy, well, we got to document their underlying conditions. And like I said before, I had a patient who had some history of autoimmune vasculitis and some cardiac history, and I said, is this really the patient that I want to give IO therapy to? And if so, how am I going to do this safely and correctly? We have to look about their history of autoimmune diseases, medication histories. As some of these patients accumulate this list, sometimes they don't know that they have conditions that might affect their ability to tolerate immunotherapy. And so I think you really have to, some degree, be the first line of defense, look into their history and really give it an honest assessment as to, is this patient going to benefit from what you're going to give them? And as part of that, it's counseling, right? So are they going to, what's the benefit? What's the risk? And you have to convey that to the patient when you're talking to them about, do they want to undergo this therapy? Certainly in the advanced, metastatic setting, maybe they don't have as much of a choice as the adjuvant setting. Reproductive status, breastfeeding status. We know that based on the mechanism of action, these IO therapies can have some potential toxicities, and so we need to counsel patients, women who are of reproductive age, who are breastfeeding, appropriately about that. And each drug has their own set of guidelines that you can refer to about what the appropriate recommendations are. Wallet cards and other identification. I don't know if you guys have experience with this. I've had a number of different approaches to it. Do we give them a wallet card which says I'm on a therapy, and if so, which one? Some of the more tech-savvy people have put it into their phones with their medical IDs and whatnot that they carry on. I don't know if you guys have any strategies, or if you guys
We have a wallet card.
Yeah. And does it just say what therapy they're on?
It just says immune therapy.
Yeah.
Yeah, it's not specific.
Yeah.
I mean, I think that just the fundamental point is critical because, again, in the community, you're dealing with oftentimes rural patients. They may go to smaller facilities first. I've kind of always heard the story and been somewhat scared of the patient that looks like they have pneumonia, and they just didn't tell the provider that they've been on IO therapies and they have pneumonitis and they're sent home with antibiotics. And it may be an oversimplification, but I think it's really important that the patient understands what they're on and is able to communicate that with the provider.
Yeah. And so that's what we do prior to starting any therapy. A very detailed health assessment, really identifying, is this the right patient to get the therapy, and what are my levels of suspicion, and when should I potentially intervene? That's done largely by the provider. So, that's me looking through the records, me consulting with the medical oncologist, any other specialists to get the workup to know that we're safe to proceed. The next is really what do we do in terms of patient instruction? So we notify the healthcare providers of any new signs or symptoms, having the primary care provider, having any other specialist involved, very helpful. And so patients have to let us know what's going on with them. And this is where I think the infusion nurse, your nurse navigator, the person who checks in the patient, all have a very vital role, especially when you're starting out with these programs, because you really don't want to overlook anything. I was not exactly sure what I was looking for, and so I just tried to make sure as many people asked the patient how things were going and if they had any new symptoms. As has been alluded to in the past, there's no symptom or sign too small to be mentioned. I think especially as people are starting up with these programs, it's a good idea just to document every little potential concern they have, and some of these turn out to be nothing. Some of them turn out to be something and warrant evaluation, but you have to get in the process of being very diligent and thorough with your workup. Symptoms should be monitored for 1 year after completion. So when we give this to patients, it's important to tell them, just as we've looked at sort of the kinetics of these adverse reactions, that just because you're not getting an infusion doesn't mean you can't have a reaction. And even when you're done with therapy, you still have to look out for them. So letting patients know that this is a process and they're an active participant is critical.
What's the latest you've ever seen an IO-tox after they've been off drug?
I don't know. I mean, again, I'm mostly treating people in the advanced setting, so it's a little bit different, but it definitely can happen, but it's not very common at all. So but I've heard up to a year or so, but I think it's uncommon.
I mean, is it safe to say that if someone cruises through a year of adjuvant pembro and they really don't have any issues, which is, I would say somewhat common, that the counseling should be, well, something may happen, but it's very unlikely.
Yeah, I think that's fair. And you're going to see them every 3 or 4 months for scans anyway, so.
Yeah. Tom, how about you? Have you seen people after therapy is complete have a new adverse?
No, I mean, I've seen the literature and the data that, they can have kind of these unpredictable side effects afterwards, but I haven't seen it.
Yeah, neither have I. And lastly, in this workflow is how do we manage toxicity? And we've been over this, so I'm not going to go into it in all that much detail, but some of the things that weren't mentioned, we review medications for drug-drug interactions. So when a patient comes in, we're trying to treat them. It's really important to get a very thorough health assessment, and so looking for any possible changes is important. As both speakers have presented before, the treatment really depends on the severity of the adverse reaction, and so we have to do a good job of assessing the severity of it before we make that treatment decision. Like I said, I like the ASCO guidelines, a set of tables with dermatitis. Here are the criteria. Here's what you're going to do for each one. And so I quite literally have it on my phone. I hand it out to the people in the team and say, this is what I think we're going to follow. I don't know what other people do, but having a good game plan, I think, puts everyone at ease that no matter what happens, we know what to do. Okay. Questions to ask patients, and so this is, when we're the patient themselves is the centerpiece of this, and so everything has to revolve around them, and part of that is, well, have you ever received immune checkpoint inhibitors, immunotherapy? We know these can occur after, and so, like I said, very important to allow patients to know that even when they're done with therapy, they may experience some of these side effects. Wallet cards, I think if you just look for it online, I bet you could do it. I tried doing wallet cards. I didn't find all that much success on it. We toyed with the idea of having little bracelets that said you're on immunotherapy, like a medical ID bracelet. But I think if we stress, in my experience, if we were stressed to alert providers whenever there was to mention that patients were on immunotherapy, I thought we had a pretty good response that patients really reported that as soon as they spoke to another member of their care team. Autoimmune conditions, as you have heard, can complicate matters, and so it's really important that when we talk to patients, assess them, that we're aware of the severity, what they've had before, and how it may affect their future treatment. So here's a case. I tried to select some cases that were a little bit off the wall just because we've been through some of the more common ones. And so this is an 81-year-old man. He has CKD, pan-urothelial disease, right? He has some comorbidities: spinal stenosis, osteoarthritis, hyperlipidemia, AFib, CKD. In my mind, none of those really raise, I mean, the CKD obviously, but Tom, any of these comorbidities raise any red flags to you? The history of AFib, does that ever make you?
What's the, I guess I would just ask, what are you treating him for eventually? I think you'll probably get to it here. Is it BCG unresponsive disease?
Yeah,
or is it? Yeah, I mean, I think this is kind of some of that art of medicine stuff that we talked about. I personally just, I really reserve IO in that indication for patients who just don't have any other options. Yeah. So they really don't want Gemdosi. There's no trial that we can get them on. As you know, there's going to be a flurry of new indications over the next 12 months in this exact situation. So I tend to really reserve IO even in healthy patients, honestly. The example I gave was a patient who was catheter intolerant. So I think that could be a role, but honestly, someone like this, I would look at all of this and say probably not. But I certainly understand, that if there's really not much there, or the patient comes in and they're really excited and they understand the side effect profile, that you can let it go.
And that was sort of my thought. I saw all these comorbidities. I'm like, oh, this spinal stenosis, is that going to somehow be affected by any therapies? And ultimately, we proceeded with this. So their history is as follows. Back in 2018, they underwent a left nephew. They had PTA disease throughout the left upper tract. Ultimately, they recurred in their bladder. It was low-grade, non-invasive. After a discussion, they underwent some BCG. They underwent maintenance, or induction and maintenance, and then high-grade disease was found. And then in this workup, we found that they had multifocal high-grade in the upper tract, and no disease elsewhere, so hopefully localized to the urinary tract. We brought this patient to our multidisciplinary team and said, well, what should we do? After that discussion, which the medical oncologists actually were very, very helpful at weighing in, they said, well, off-label Pembro might be reasonable, and so counseled the patient appropriately, and ultimately gave it to him. Cycle number 12, the patient reports fatigue and a decreased appetite. These are, I think, teased out by our nursing staff, and as we did with all of our infusions, we checked some thyroid functions, and we saw that the TSH was slowly creeping up. I think at the time of, previously it was 6, and then we monitored at 13. We said, well, I don't know exactly what to do. Let's check it a week later, and I think it was 31. And so the question is, well, patient on Pembro for quite a while, what would we do in this setting? So we can stop the therapy, we can give steroids, we can give thyroid replacement. What do you think is the best? Obviously not the most straightforward case. Maybe I'll ask you guys, what would you do? So,
generally for hypothyroidism, I would just continue immune therapy and replace. And I agree, minor TSH elevations, I don't really do much about and observe them because you see them all the time. And, it's just yet another pill that this patient has to take every day. I guess because of the setting in which this patient's getting it, it's kind of like backing up and saying, are we going to continue Pembro forever here? Or, that's sort of what I would start thinking about.
Yeah.
You're lucky
Yeah.
it was just thyroid, but
Yeah.
again, given their 80 plus and some frailty, I'd be concerned that if this patient got colitis or something, their ability to withstand that is low.
Yeah.
Yeah, I agree. I think I'm not a huge fan of IO for upper tract disease. I think there's some data that especially in the Nevo data, that adjuvant for upper tract really didn't have much of a benefit. I think the diseases are a little bit different. But I think the point's a good one, especially in the community. You're kind of hamstrung with some of these, especially these urothelial patients who are older. You can't give them platinum. You don't want to do something that's super morbid. And so sometimes this is like can we punt a little bit? Can we just kick this down the road a little bit? So I think it's interesting, and I've definitely seen this kind of approach for patients who maybe are muscle invasive and you don't want to do a whole lot and kind of keep them going. So, but I agree. I think in this situation, I think you're like, okay, well, we tried it. This didn't go very well. Let's give them thyroid replacement, and I'd probably stop, honestly.
Yeah. Just for my own discussion purposes, Tom, would you treat this patient in the community setting? Or would you refer to medical oncology?
Yeah, I think it's tough because it's a kind of a weird case, right?
Yeah.
So he's got bilateral upper tract high-grade disease. We don't, that's not really an indication for any systemic therapy right now, unless you can prove that he's got node-positive disease or he's really got locally advanced disease. So I have had a few of these patients. I think that it's a hodgepodge. I think sometimes you try to clear patients out, make sure they're not obstructed. Sometimes they live with a stent, and I endoscopically manage them, every 3 to 4 months. There is some emerging data that maybe mitogel upper tract, right? Gel mito may be effective, although it's indicated for low-grade disease. I don't think that's wrong, and I've actually even had a patient where I've given IO and done gel mito, because the patient couldn't get a nephroureterectomy, and we're just trying to, and again, multi-D consultation, talking to people, and definitely telling the patient, listen, here's where we're at. We can't do aggressive surgery on you. This may work, it may not. We've got a short leash to pull it off. And let's go from there. But I probably would not put this patient on IO monotherapy.
Yeah. This was a patient that was seen at Washington University in the academic setting, and I thought, well, is this someone I'd treat out in the community? And I agree with that discussion. It may not be appropriate, but I think I still would have gone through the same process. In terms of like setting up the multi-D, trying to make sure you go through all the right steps. I think if I had done this in the community versus in an academic environment, the end result would probably be the same. I wouldn't necessarily shy away from treating in the community, but I would want to make sure that all team members bought in, that we had discussions with the
I think it
medical
just makes you
oncologists.
feel better. I've had plenty of 83-year-olds with muscle invasive disease that can't get a cystectomy, and we send them to medical oncology, and sometimes medical oncologists will put them on checkpoints. And it's kind of off-label, but I think that's part of it, is just having this discussion. Maybe they get a little bit of RT to the bladder, and they're on a systemic agent. It's just a better call than doing it by yourself and kind of saying, hey, let's just see where this goes, because again, this is kind of a multi-D type of disease. I don't know if Dr. Rini has any thoughts on kind of these off-label types of situations.
Yeah, you end up sort of piecing it together, right? When they can't do this and they can't do that, and so you do things that are a little outside the box. But I think it's fine. Obviously, you're trying to do no harm to patients, but yet control their disease. I think it's fine.
Yeah, okay. So the endocrinopathies, from a urologist standpoint, we give a lot of the PD-1, PD-L1 therapies, not quite so much the CTLA-4s. But if we look at these, you can see the rates of the various endocrinopathies in this graph here with hypothyroidism, hyperthyroidism, and hypophysitis. And you see that when you start giving these in combination, that the number of, or the incidence of these endocrinopathies start to increase. And so just something to keep in mind, that as you start adding on therapies, you might have to start counseling patients about increased rate of toxicities, and as well monitoring a little bit closer. So as this slide will show, we monitor the TSH, the cortisol level, but with a lot of these endocrinopathies, the symptoms are pretty non-specific. And so it's really important, again, to get as many touch points on the patient as you can. And with the endocrine, as our team was mentioning, it's one of the adverse events where we don't necessarily have to discontinue therapy. We don't have to necessarily give steroids. We have to kind of gauge how severe it is, what their side effects are, and base our therapy based on that. Patients who have diabetes, on the other hand, who get type 1 diabetes because of pancreatic involvement, potentially life-threatening, they're going to need long-term insulin therapy, essentially indefinitely. We need to get those patients in. We need to get them established with an endocrinologist as soon as possible. And so whenever we're monitoring these, very important that we not only say, what type of adverse event they have, but also what's the long-term outlook for that treatment. Is it something where we're just going to monitor for a couple weeks and lay low? Do they need an evaluation right away? Examples of immediate ones. Anyone with a vision change, automatically send them, whether or not I suspect it's immune mediated or not. If they say that they're having some change in their vision, I send them to ophthalmology just to make sure that I'm not missing anything. Changes in blood sugar, send them to an endocrinologist. It's just important to me to make sure that we monitor those closely. I think this is my second and of 2 cases, and again, just highlight some of the more odd ones that I've encountered. So, 67-year-old man with high-risk prostate cancer and essentially no comorbidities. He's the guy that you want to treat for prostate cancer, counseled. He got his treatment before, or his surgery before I showed up at Washington University, but he had grade group 5 disease. His PSA was 6. He had his prostatectomy in 2017, T2C, node negative metastatic workup by conventional imaging as of 2017. Did well for a year. Functionally, he did fine in his recovery, but his PSA came back at 2.1, approximately 1 year from surgery. Did the metastatic workup, bone scan in his left scapula, had lesion-targeted disease, got radiation placed on androgen deprivation. PSA went down, stayed down for 2 years, and at that point, he's like, guys, I'm miserable. Can I come off of this ADT? Careful discussion, came off of ADT. Year later, PSA comes back. 1.2, now has a lesion in his rib. We restarted androgen deprivation in him. PSA drops. So previously 1.2, now it's 0.25. 1 year later, PSA starts to climb again. So now castrate-resistant disease, metastatic, essentially asymptomatic. He undergoes Provenge. PSA slowly starts to rise, and so this is now 5 years later. So he's in his early 70s, starts to rise, and when he was seen late last year, his PSA was 4.7, and we said, look, it's continuing to rise. What can we offer you? Let's get you on a trial. And so, being at the academic institution, he was enrolled in a medical oncology trial, which involved a DNA vaccine plus Pembro. He got 1 dose, and 2 weeks afterwards, this is how he showed up. And so I was in clinic with my medical oncologist, and he pulled me out to evaluate this. And I'm like, I've never seen any real neurologic problems, but he had this left eye edema, symptosis. He was seen just fine. He didn't think much of it, but we had looked back at his, we said, well, this needs to be evaluated. Let's get some workup on you. And sure enough, previously his liver enzymes were normal, and now they started to rise, and we are checking on this weekly. And so ophthalmology was involved, and they said, well, possible myasthenia gravis. This was all done, the workup from his, initial presenting symptom to the ophthalmology consultation was in a matter of days, if I remember correctly. But they said, well, possible myasthenia gravis, and they had said, well, let's give him some prednisone. His lab values started normalizing. We got a bunch of antibody testing, again, done through this multidisciplinary team. Everything was negative. MRI was negative. And his PSA actually started to decrease. This was essentially in just a few months ago, and I haven't updated to figure out what his latest PSA is. But the point was that when the guy showed up with this relatively rare adverse event, I wasn't sure whether or not it was trial-related, or pembro-related, but we had a workup in place. We knew what we were doing because we were monitoring routine labs. We had our team on standby. We admitted him to the hospital. We had a guy who knows how to manage immune-related ophthalmologic concerns, and so quickly able to work this up. I don't know, Tom, if you've ever seen any neurologic problems with IO therapy. This was the first that I was like, well, this is something a little bit odd.
Yeah. No, I mean, like I said, I think this is just behooves the notion of if something new has happened after the onset of therapy, it's most likely related to IO. But this is an interesting situation because you have another agent that you're giving the patient, and so you have to kind of exclude. But really, I mean, there's no harm in sometimes starting steroids. Obviously, you don't want to commit them to long-term steroids, or getting multi-D collaboration and getting the specialists on board to weigh in on it. But yeah, this is something a little bit scary, and again, this happens, and you have to, if you're going to give this stuff, you have to be able to understand, okay, well, what am I going to do if I see this person in the office? Because sending this person home and saying, hey, I think you're going to be okay, or I think we'll give you a couple weeks of steroids and we'll see what happens, is not going to be, I think, appropriate. I think you have to take some of these rare ones a little bit more seriously because there's data that says that the rarer side effects can progress a little bit quicker, probably that they're underdiagnosed, underdetected, and so some of these ones that are, we're so used to rash and dry cough and thyroid, and we know how to manage those, but for these, I think you have to have really a high antenna about getting them in to see somebody soon.
Yeah, and I think to your point, the reason why I like this was because we had this workflow in place. How do you treat a patient, whether or not they have a cough or a rash or drooping of their left eye. I think you should approach it with the same mindset of, well, we got to screen for symptoms. When we do have a symptom, we have to assess how severe it is, and based on the severity, we need to have a plan already in place on how we're going to treat that. Just to talk about myasthenia gravis as an adverse event, obviously rare, but history of weakness that's fluctuating, worsening over the course of a day. Greater than 50% may have some ocular muscle dysfunction. Patients can have different symptoms. 4 weeks or so after initiation, obviously in ours it was just a couple of weeks after the first dose. The testing. This is, if I were doing this on my own, I would have no idea what to test for, but because we had this team getting an EMG, acetylcholine receptor testing, anti-striated muscle antibodies in the blood. I've never ordered these in my life, but like I was talking about how each member of this team has their own superpower. We have a guy who said yep, this is exactly what you order, and so it took a lot of the anxiety off of me because I knew that there was someone who knew how to handle this. So treatment, admission to the hospital, make sure that there's no medicines that are going to worsen the myasthenia gravis, things like beta blockers, fluoroquinolones. And the treatment, acetylcholinesterase inhibitors for milder cases, steroids for more severe cases, and there is a mortality rate associated with it. So ultimately, when this patient got their workup, it was unclear. Everyone was still debating, was this really myasthenia gravis? Because all these tests were coming back negative, but they responded to what we were giving them, and ultimately the swelling went down, function returned, and the patient was no worse for wear. So we've talked about the guidelines a little bit before, but there's a number of different guidelines, and when you're trying to operationalize this, I think that the key is you pick one and you stick with it, and so that there's a common playbook across your team. There's benefits for you, for the community, for the patient when you develop this team. So I listed just a couple here. Interdisciplinary communication and education. As you know, treatments in cancers in urology are becoming more and more multimodal earlier and earlier in the disease space. And so these types of communications are very important to let all your team members know what you're doing and just to foster these good relationships. We know that patients are appreciated. When you have a lot of nurses who care, front desk staff, medical oncologists who are all communicating with each other and with the patient, it leads to patients feeling that they're being managed correctly, that they're managed safely, and so I think the patient experience has been really positive when patients know that there's a whole team that's looking after them. And importantly, these safety nets, these multidisciplinary teams are not new. They exist in the community already. Because immunotherapy has been given by the medical oncology community for quite some time, they have their endocrinologists, they have their dermatologists, and so we just have to make those connections. And so it's not as if you have to start from square one, you just have to figure out who the people are who are used to treating patients who have received immunotherapy and linking them all together. When I did this in private practice, I made a lot of connections. I found the endocrinologist, and they said, well, yep, this is the GI guy who we usually use as well. And so it was very nice because you didn't have to hand select everyone. They already had that team already coexisting.
Yeah, I mean, I would just say that a lot of this in private practice stems from, I think, having a high-impact GU multidisciplinary tumor board. I think a lot of our facilities have tumor boards, but I'll be honest with you, I don't think those are the best forums because they're presenting mostly colon and melanoma and breast. And so in my experience, I kind of pivoted away from a hospital-based tumor board and kind of focused on people who are interested in GU, and now we do a weekly virtual tumor board with people who are really interested in GU. And what that kind of begets is they're experts as well. So the medical oncologist will say, hey, here's who I use for my GI consultations, hepatology, endocrine, and those people essentially become part of your Rolodex as well. So I think that this starts personally with a really good and kind of well-planned. And in academics, it's a little bit different. I think you have those people coming into the table already, but I think in the community, I think you've got to try to find people who are really interested in GU and kind of work forward.
So these two columns, I think, are very important. So on the left, it's who are the people that we should be engaging in our multidisciplinary team, and primary care providers, obviously important. The emergency department, right? These are the patients, you send them to the emergency department. They need to know how to manage patients who are having adverse events. The hospitalist obviously may be admitting your patients. IO champions are very important. Like Dr. Jairam was saying, this isn't for everyone, and so it's important that you identify someone in your group who wants to take this on. And it's not a small undertaking, and I think you have to take it seriously. Having mid-level providers is key, and the pharmacists are also exceedingly helpful. And how do we reach out to them? Well, the column on the right has this. So education outreach, very important. Dr. Jairam was mentioning tumor boards. I've given a similar talk at Grand Rounds to the urologists. I wouldn't mind doing it to our emergency medicine doctors. Having an IR tox team. Personally, we haven't set that up at Washington University, but it makes a lot of sense, and I've heard that it's successful at other institutions. Having a group of people, just your go team, patient comes in with an adverse event, we know what to do, and here's the list of people who are skilled, qualified, interested in helping. How do we do this? This is all cyclic, and again, the patient should probably be in the center of this, but if we start at the top, our goal really is to prevent these adverse events, and so the only way we can do that is to understand what they might be and to anticipate them. Early identification, appropriate treatment, knowing what to do and what not to do, and monitor them throughout. And as the team builds more and more experience, they get more and more insight into what to expect and how to manage it. And I think every institution is a little different. I'm sure Dr. J. Ram's team works a little bit different from my team. My team at Washington University works a little bit different from my team in Oregon. People have different roles. People feel comfortable doing different things, but regardless, you have that team in place. Technology is our friend, and in private practice, we used to do a lot of phone-based care, and so we called the patient before their infusion to make sure everything was okay. We got the laboratory testing, we infused them, we monitored them. Day after we called them, a week later we typically reached out to them just because we wanted to be very, very careful. Nowadays, I may not feel the need to monitor them quite as closely, but that depends on your level of comfort. Virtual visits with telemedicine is very helpful. You know, patients say, well, I have a rash. Well, maybe we can just FaceTime and look at it right now. Is this something, how bad is this? And so I think you need to figure out whatever technology you have, figure out how to leverage it to your abilities. And obviously, you know, bladder cancer patients, maybe an older population, may not be as tech savvy, but you have to gauge that and have these tools at your disposal. Here's a workflow at the bottom. You know, your patient calls, they have diarrhea. Well, the triage nurse is notified, and then the triage nurse triages the clinical concern. They ask a bunch of these specific symptoms, questions that we provide the triage nurse, as well as additional IO-specific questions. And so educating your team as to how to manage this saves you a lot of work. So you're not just getting the phone call, patient has diarrhea, what should we do? And you're having to start from square one. You can get a report saying, well, your patient has diarrhea, it started this long ago, here's how many episodes, do they have anyone sick? And you can really cut down your workflow, make it a very, very quick decision. And so the take-home points, and afterwards, we have a little bit of time. I'm sure Dr. Jaram, as well as myself, would be happy to answer questions, but immunotherapies are here to stay, and they're going to be increasingly utilized in urologic cancers earlier in the disease space through a variety of ways, and so we have to get used to them. There's never going to be a treatment that doesn't have side effects, and so we need to accept that they will occur. And if you want to give these therapies, you have to understand that you're going to be dealing with them. We know that our job is to keep patients safe, and safety is optimized when we identify these early, treat them in a timely way, bring in the experts that we need, realizing that urologists aren't experts in all of these areas. We need overlapping systems to prevent, anticipate, identify, and treat these to ensure the care is appropriate, both from our perspective as well as the patient's assessment of their care. And there are multiple resources that we can use to assist urologists in how to manage these. And so we just have to really reach out and leverage what's already out there. I think that was
Yeah, so I think that's pretty much it that we had. We tried to kind of cover a little bit of everything in terms of, the side effects, where they come from, how to manage them, and then kind of what the overall approach should be. And, we're happy to take questions kind of here or kind of aside after the program. But I appreciate kind of people coming, and I know there's some people watching this on live stream as well. And I think I just had to check the app to make sure there were no live stream questions. That was one thing that I was told to do. But if anyone has any questions, feel free to shout it out. But otherwise, we're happy to stay around afterwards and chat. So thanks for everyone's time and attention. Thank you.